I have the sweetest job of the day because I get to introduce a lot of people who are my heroes and heroines. So I'd like to introduce now Greg Millett, who is Vice President and Director of Public Policy at amfAR. Before joining amfAR, he served as the HHS CDC liaison to the White House Office of National AIDS Policy. From 2009 to 2011, he served as detailee in the White House Office of National AIDS Policy as a senior policy advisor. In this role, he coordinated the office's policy and research activities, including HIV prevention, policy, and federal level interagency process to develop the national HIV/AIDS strategy. Mr. Millett has a Master of Public Health from University of North Carolina at Chapel Hill. And another point of personal privilege, I've stalked Greg for years to be a part of a housing conference, so please join me in welcoming him.
Hi, good morning. It really is a privilege to be here and a privilege to be invited to such an incredible meeting with both Steve Shoptaw as well as Nancy Bernstein. And I can tell you, for the times that I was in the White House and we were pulling together the National HIV/AIDS strategy, we'd get these periodic emails that would be coming through, and it's just from Nancy, housing. So I mean, just to let you know that, I mean, she's just such an incredible advocate and someone who's going to be sorely missed. But you really have just done such incredible work, and we're really thankful that you have. Today I wanted to talk a little bit about the structural factors and the HIV care continuum of care. I am going to talk about housing, but I wanted to broaden the discussion a little bit to a lot of the other structural factors that really affect people living with HIV in the continuum of care, just to get the conversation going about the degree to which all of that is interrelated. So Douglas already showed you the continuum of care. One thing that I was really struck by is by the disparities by demographic groups across the treatment cascade. When you take a look at research studies over and over again, you find that there are specific sets of demographic groups that are affected at each level of the cascade. And surprisingly enough, a lot of these groups are consistent for just about every outcome of the cascade. So you constantly see non-whites, you see men who have sex with men. For several parts of the cascade, you see both men as well as women. You see youth. You see injection drug users all over the cascade, particularly for being less likely to be virally suppressed. And then you also see transgender populations in two specific parts of the cascade as well. So there are specific demographic groups that are at higher risk for falling out of the cascade or for not achieving outcomes in the cascade compared to others. And that's something that's very real. And if I just want to elaborate a little bit more on some of these groups, and the first one being, foreign-born Latinos and HIV outcomes. If we're going to be serious about the treatment cascade and really reducing the number of infections in the United States, we are going to have to figure out a way that we can get adequate not only housing but health care for people who are foreign-born in the United States. There are data that were published a couple of years ago looking at immigrants versus U.S.-born individuals, where they found among those who are HIV positive, those individuals who are immigrants had a higher prevalence of opportunistic infections and more likely to be hospitalized compared to those individuals who are U.S. born. And when they looked at this in multivariable analyses, they found that just being an immigrant alone had an independent association with a greater likelihood of having an opportunistic infection. So that is really important information. And then we also know from data from CDC that when you take the look at the US-Mexico border, that 46% of Latinos are diagnosed late versus 37% of whites, that there's a higher proportion of late diagnoses among foreign-born compared to US-born Latinos, and that there's increased risk of delayed diagnosis among foreign-born versus US-born males. And here in LA County, Spanish-speaking Latinos are 3 times more likely to present late compared to English-speaking Latinos. And we know that there's greater mortality rates among Latinos in Puerto Rico than mainland US. So obviously, if we're thinking about the continuum of care, we can't think about the continuum of care without also thinking about some of those groups that are somehow being left behind in some of the efforts that are going to be taking place both at the federal as well as the local levels. We also have HIV-related disparities by sex, by gender, when we talk about the continuum of care. For women, it's a bit of a conundrum because you find that women are more likely to be engaged in care, but not necessarily getting the same outcomes as compared to men. So we have higher diagnosis rates as well as higher CD4 among women, but women also don't necessarily have the same amount of time in care or on antiretroviral therapy compared with men. Women also are significantly less likely to use primary HIV care services and are more likely to use greater use of emergency department services. And even though we have mortality rates that have been decreasing in the United States across all groups, you still find that in certain parts of the United States that mortality among women exceeds that of men. So there's definitely some issues that need to get done to address disparities among women. And I'm very happy that Douglas highlighted a lot of the incredible efforts that have been taking place in the White House in terms of the nexus between violence against women as well as HIV. And one thing I wanted to bring up really briefly was a case that took place in Dallas. And I know that many of you, when you think about Dallas now, that many of you probably think about Ebola. But 2 years ago, when we thought Dallas, and this happened right on the heels of the International AIDS Conference, which made it so shocking, was that there was a woman named Cicely Lee Bolden, who you see here, who disclosed to her male partner that she was HIV positive. When she disclosed, he nonchalantly just went into the kitchen, took out a butcher knife, and stabbed her multiple times and killed her. This is something that is an issue that we have to deal with as well among women, domestic violence. Douglas showed you briefly that there are several studies, meta-analyses, that have looked at women living with HIV and found that there's a 30% PTSD among this population, which is 5 times the national rate, that 55% have experienced some sort of intimate partner violence, which is 2 times the national rate, and that recent trauma is actually associated with a 4 times greater odds of antiretroviral therapy failure for women who are living with HIV. And also in several of these studies, we found that domestic violence doubled the risk of death from women living with HIV. So when we look at the continuum of care, we also need to be specific with some of these sex and gender issues that are taking place in the continuum of care. There's also issues when you took a look at the group that really is most impacted by HIV, at least now in the United States. You look at men who have sex with men, and particularly black men who have sex with men. My colleagues and I, when I was at CDC, we undertook a study to take a look at all of the studies that have been published looking at HIV-positive black MSM compared with white MSM to see if there were differences in terms of the continuum of care. And what you could see really briefly here is that, black MSM were about 6 times more likely to be diagnosed, have undiagnosed HIV infection compared with white MSM. They're 3 times more likely to have HIV compared with white MSM. They're about 50% less likely to utilize antiretroviral therapy. They're about 60% less likely to have a CD4 greater than 200 at initiation of antiretroviral therapy. HIV-positive black MSM are 40% less likely to have healthcare visits compared to HIV-positive white MSM. They're 50% less likely to have access to antiretroviral therapy or to adhere to it, and about 50% less likely to be virally suppressed. So you find that at each level of the treatment cascade, and these are studies with well over 600,000 MSM, so these data are pretty powerful. You find that these disparities exist by race and ethnicity, even among MSM, the group that's highly impacted by HIV. And not unsurprisingly, one of the major factors that we see that might be associated with these disparities is income. HIV-positive black MSM were 3.5 times more likely to have an income of $20,000 or less compared to HIV-positive white MSM. And also, HIV-positive black MSM were 50% less likely to have health insurance compared with white MSM. So these structural issues keep coming into play as to some of the reasons why we're not making the progress in the treatment cascade that we should be making. So that, I think, is a good segue to talk about what these structural issues are and where do we see them on the treatment cascade. Just as you see specific demographic groups for each part of the treatment cascade who are not doing as well as they should, you see that there's certain structural factors that are associated with why we're not doing as well on the treatment cascade in the HIV care continuum as we should. Those include not having access to health insurance. It includes low income. It includes housing status. It includes food insecurity as well. I mean, every part of the treatment cascade, when you look across studies, you find that many of these structural factors are associated with not achieving the outcomes that need to be achieved for the treatment cascade. And when you take a look at AIDS mortality disparities, I discussed this really briefly with women compared with men. But unfortunately, you find these disparities overall in the United States with many different groups. So even though AIDS deaths have declined because we've had antiretroviral therapy since the mid-90s, among people living with HIV/AIDS in the South, they've declined least. Among Black and Latino MSM relative to white MSM, they've declined least among those groups. Among Black women, they've declined least compared to white men. And among Latinos, AIDS mortality disparities have declined least compared to Blacks or whites. And really, one of the more damning things to show the degree to which many of these structural issues are associated with AIDS mortality in the United States is that there have been several studies that have found that there are actually less disparities between Blacks and whites before antiretroviral therapy was available. So there was less disparities in terms of mortality before antiretroviral therapy was available. And when you take a look at the period after antiretroviral therapy, you see that bar that goes up where there is a bigger disparity in mortality between Blacks and whites after it was available. And the main reason, of course, is less access to healthcare in these communities. So we have antiretroviral therapy, that's great. There are some groups that are getting it, but then those groups who are really most at risk are still not getting it. And they found exactly the same types of disparities by income, where before antiretroviral therapy, they were there, but they were not as large. But as soon as antiretroviral therapy was available, those people who are low income were less likely to get it, and you had these huge explosions in mortality rates among lower income people. And we don't just see that among people who are in care, we see it as well for HIV infection. Many of you know about the National HIV Behavioral Surveillance Surveys that CDC does. One of the things that they find out over and over again is that there are differences by structural issues among those who are HIV positive. So we find that those people who have no high school education, those people who are unemployed, those people who are below the poverty level, and those people who are homeless are more likely to be HIV positive in those 21 or 22 cities where the CDC collects data as compared to those people who have access to each one of those issues. And we also see that there's regional variations as well in terms of antiretroviral therapy initiation and survival, with the southern United States doing far worse compared to the rest of the country. And this, of course, impacts, again, how we deal with the treatment cascade and continuum of care. Where you could see the map of the US, the dark blue are those places where there's a really high case fatality rate, extremely high case fatality rate for people living with HIV, and that's primarily concentrated in the South. And then you could see the graphic that I borrowed from colleagues from CDC, where we looked at the percentage of diagnoses by AIDS by region. And one thing that's very clear by that is that there's been an increase between 1981 and 2009, and that's actually gone past 2009, in the number of AIDS diagnoses within the South as compared to all other regions. And when you look at the South, PWAs from other regions are more likely to initiate antiretroviral therapy treatment as compared to the South. And among Blacks and Latinos, survival after HIV diagnosis is worse in the South compared to other regions. Okay, looks like I'm stuck. There we go. And then housing in the HIV care continuum. Some of these data were already talked about a little bit earlier today, but we know that people who are HIV positive and homeless or marginally housed, that they're about 5 to 10 times more likely to be HIV positive compared to those individuals who are housed. And that being marginally housed is also a risk factor for shorter time to seroconversion as compared to those individuals who are housed. We also know that homeless PWAs are less likely to have a CD4 that's greater than 200 or an undetectable viral load compared to those PWAs who are housed, and that homeless PWAs have a greater mortality rates as high as 10 times greater than housed PWAs. So what does this mean for our efforts for the treatment cascade and the continuum of care? There's been a lot of talk about seek, test, and treat, where you seek those individuals who are positive or may not be diagnosed, test them, and treat them. But how can you seek them if people don't have an address? How can you seek them and test them if people don't have a physical place where you can find them? And that brings up a whole lot of issues for us to deal with. One thing that I want to talk a little bit about is the fact that when we look at structural interventions, there is a lot of debate within the scientific community about the degree to which structural interventions can or cannot be helpful, particularly because the barn is on fire in terms of HIV in the United States. One of the reasons is, A, structural interventions are incredibly expensive. They are very hard to measure, at least from the scientific part. You can't tell how much of that intervention is, or the changes are due to your intervention or due to something else. They take an incredibly long time to implement, and quite frankly, when we have huge infection rates right now in particular communities, we don't have the time to implement some of them. They're not a one-time intervention. It's something that's going to have to take place over and over again, not just something that takes place once. For instance, the ACA, it's not just everybody has the ACA now and then everything is fine. It's something that we have to be really proactive about for quite some time. There's also counterintuitive effects for some of the structural interventions, but don't necessarily go in the direction where we think that they should go. And the other thing about structural interventions is the fact that they sometimes, have this belief that communities are somehow hopeless, that we need a structural intervention that's going to somehow change or save communities, without realizing the fact that there's already innate resiliencies that's taking place within these communities. So, for instance, you see over and over again with data, particularly for Black gay men, they're more likely to be homeless or unstably housed, more likely to be unemployed, more likely to not have access to care. But when you take a look at their prevention behaviors compared to white gay men, they're still 40% more likely to engage in any type of prevention behavior, despite the fact that all these structural issues are there. So, there's some issues there in terms of being able to recognize resiliency within these communities. But that said, with all the issues with structural interventions, quite frankly, there's nothing else that has the potential to affect so many people in the United States and to really address the epidemic than to have specific structural interventions. And when we take a look at the National HIV/AIDS Strategy, there have been several milestones in structural intervention since the release of the strategy. I'm not going to go through many of these. A lot of them are highlighted in red since the release of the strategy in 2010. There's been specific policies that have been taking place that have really mitigated some of the effects of not being able to get people in care in the United States, which have just been incredible. All the way down through 2013, there's just been some incredible work that's been done at the federal level and the structural level with some policies that have really made an impact. And one thing that I wanted to highlight is when you take a look at this timeline from the very beginning, there is one point, and you can see this in September 2011, the last bullet point, where national ADAP waiting lists peaked at about 9,000 individuals. And then by 2013 December, there were only 11 people who were on the ADAP waiting list. So there is a lot that can be done. There's a lot that can be done and has been done at the federal effort in terms of some of these policies to really make sure that we try and address the continuum for those individuals who need it most. So beyond that, we also have to focus beyond HIV and realize that there's an agenda going forward that this administration is taking place that really affects a lot of the populations that we're dealing with today. The fact that we don't have minimum wage, across this country is a huge issue, particularly for people living with HIV. The fact that we don't have equal pay for women, and that's not been able to pass through Congress, is a huge issue, particularly for those women who might be in situations where they're dependent upon a husband who beats them or somebody who does not take care of them, and where they need equal pay so that they can at least move out of the house and take care of their children. Immigration reform, not much to say there. It's pretty obvious, I think, to all of us how that impacts people living with HIV, particularly with some of the data that I provided to you beforehand. Other policy issues that matter are equal benefits and rights for LGBT people, which this administration has championed and which has obvious effects for people living with HIV. Douglas had mentioned ACA implementation and how important that is as a structural intervention for people living with HIV. Under this administration as well, there's been an unprecedented expansion of transgender rights and transgender issues, as well as visibility for transgender issues. And a lot of the work that Douglas's office is doing in making sure that transgender women are more visible for surveillance for statistics. Douglas already mentioned violence against women and a lot of the incredible efforts that the White House is doing there. And I talked a little bit about how that's associated with HIV. And we also have My Brother's Keepers initiative in the White House to really deal with what's taking place with African American men who sadly have the highest rates of HIV in this country. And I think one of the biggest structural interventions that we have, and something that I'm immensely proud of, is that we have a person who's living with HIV who's a Black gay man, who's actually the director of the Office of National AIDS Policy and understands what many of us go through on a daily basis as people living with HIV. And quite frankly, if we don't have the right person in the right place at the right time, then we would be lost. And I'm very thankful that we have that person now. So that's all that I had to present on today. Thank you for your attention. Wasn't sure if you have any questions, but I'd be happy to answer anything that you might have. Thank you again.